Hi, my name is Janine Concepcion. I'm a very student and I'm going to be the nurse for today. So today we're going to be doing a pain management checklist with the patient. So when I first come in, I'm going to introduce myself to the patient. I'm going to check their ID band to make sure their name and date of birth matches their band, and then I'm going to wash my hands before the procedure. And then first thing I'm going to do is observe posture, and I'll make sure that the posture is upright when the client is comfortable, and make sure that they're not hunching over or holding a body part. And then I'm going to be observing their facial expressions and making sure that the client is smiling and a comfortable face and having eye contact, and ensure they're not grimacing or looking down. And then I'm going to be assessing the joints and muscles and making sure that the joints don't have any edema and that the muscles are relaxed. Next, I'm going to be observing the skin, and I'm going to observe the skin without scars, the skin color, the texture, if they're moist, and inconsistency, wounds, or any inflammation or bruising. And then lastly, I'm going to be defining cold spot. So C is for characteristics, so describing the pain in their own words and their symptoms. And then O is onset, so where the pain begins. L is location, so where the pain is, if it radiates, if it hurts in one place and another place at the same time. Duration, how long does the pain last? Does it come and go? Does it reoccur? The S is for severity, and it's how bad is it, rating the pain from 1 to 10 on the numeric scale. P is pattern, and what makes it better or what makes the pain worse. And then lastly, A is associative, just any symptoms associated with pain, like vomiting, migraine, etc. All right, thank you. The respiratory assessment. So same thing, I'm going to be introducing myself to the patient, washing my hands, checking that their ID band that correlates with their name and date of birth, and gathering my equipment. So for equipment, it's going to be gloves, a pen light or a flashlight, a small glass of water, and a stethoscope. So then moving on, I'm going to start inspecting for nasal flaring and pursed lip breathing. So I'm making sure that the nasal flaring isn't happening, and that normally that the diaphragm and the external intercostal muscles are doing most of the work for breathing instead of the pursed lip breathing. And then I'm going to be comparing the inspiratory and expiratory phases of respiration. So the outward expansion of the abdomen and the lower ribs on the inspiration, as well as returning to a resting position on expiration. So the normal in and out of expiration and inspiration. So then I'm going to be inspecting posture on my patient and making sure that they're sitting upright and they're relaxed with easy breathing and their arms at the sides or on their lap. And then next, I'm going to be inspecting the configuration. So I'm making sure that the scapula is symmetric and non-protruding, that the shoulders and scapulae are equal and horizontal positions, and making sure that the ratio of the anteroposterior and transverse diameter is 1 to 2. So next, I'm going to be observing quality and position and pattern of respiration. So making sure that the respirations are relaxed, effortless, and quiet, so there's no loud breathing. I'm going to be making sure that there are a regular rhythm and a normal depth. And then I'm going to be assessing the use of accessory muscles like the trapezius or the pectoralis, and making sure that they're not being used for regular breathing. So next, I'm going to be palpating the posterior chest. So I'm going to be turning around the prop to show you. So the position that you're going to be going in is like this. And you're going to be going in circles like that. Okay, and then I'm going to be doing percussion. So it's around the same position. So you're going to be going like this. Like that. And then next, I'm going to be doing the auscultation. So I'm going to be going the same pattern. So I'm going to be listening in. Make sure that the breath sounds are normal. I normally wouldn't move, but this, Okay. So next, I'm going to be assessing lung expansion. So when the client takes a deep breath, the thumbs should be moving about 5 to 10 centimeters apart. Okay, so next I'm going to be auscultating for normal breath sounds and making sure that the 3 types of normal breath sounds are the bronchial, which is the trachea and the thorax, bronchiovascular, which is over the major bronchi of the chest, and then vascular, which is the peripheral lung field. And then lastly, I'm going to be making sure and auscultating to make sure I'm not hearing any adventitious sounds like crackles, pleural rubs, wheezing, and rhonchi. Right. Cardiac assessment. So same thing, I'm going to be washing my hands before the procedure, introducing myself, and making sure that the ID band matches the information for the client. And then I'm going to gather my equipment, which is gloves, a pen light, a small glass of water, and my stethoscope again. And then I'm going to explain the procedure to the patient and make sure I gain their consent over what I'm going to be doing next. Alright, so firstly, I'm going to palpate the carotid arteries for amplitude and rate. And I have to make sure the pulse is normal, which is 2. And so for the list of pulses, it's going to be 0 is going to be absent. 1 is weak and diminished, so it's easy to obliterate. 2 is normal, which is obliterable with moderate pressure. 3 is strong, so it is obliterated with firm pressure. And then 4 is bounding, which is unable to obliterate. Okay, so next I'm going to auscultate carotid arteries for roots of the stethoscope. So I have to make sure that there's no blowing or no swishing sounds are heard. And then I'm going to assess for jugular venous distension. So that's of the jugular vein. So the client needs to be sitting upright and make sure that it's not distended when they do this movement of moving their head. So then I'm going to check for atypical pulsation. So the atypical impulse may or may not be visible. So if apparent, it's going to be in the mitral area, and I have to make sure that the atypical impulse is seen or not seen. And then why the atypical impulse is a result of the left ventricle moving outward during systole. Next, I'm going to palpate for the point of maximal impulse. So the atypical impulse is palpated in the mitral area and may be the size of a nickel, so 1 to 2 centimeters. And then the amplitude is usually small, like a gentle tap, and then the duration is brief. For obese clients or clients with large breasts, the atypical impulse may or may not be able to be palpable. So next, the findings would be that normally no sounds are heard. So next, I'm going to auscultate over the 5 carotid landmarks. So the first one is the aortic, which is on the second intercostal space at the right sternal border. And then the next one is pulmonic, which is the second intercostal space at the left sternal border. And then third is Erb's point, which is the third intercostal space of the left sternal border. And then fourth is tricuspid, which is the fourth intercostal space at the left sternal border. And then fifth is mitral, which is the fifth intercostal space of the midclavicular line. So the rate should be 60 to 100 beats per minute with regular rhythm. Okay, so next I'm going to auscultate for extra heart sounds, and so that's going to be S1, S3, and S4. And for S3 is usually found maybe in pregnant women or children, and it's usually not found. So then S1 is after blood flows, so it's going to be lub. And then S2 is when the blood flows out, so dub. Okay, and then next we're going to auscultate for murmurs to make sure that we're not finding any murmurs. So grade 1 is very faint, so heard when listeners tuned in. Grade 2 is quiet but heard immediately on placing the stethoscope on the area. Grade 3 is moderately loud. Grade 4 is loud. Grade 5 is very loud, and it might be heard without the stethoscope or with the stethoscope partly off the chest. And grade 6, it may be heard with the stethoscope entirely off the chest. Vascular system assessment. So same thing, I'm going to introduce myself to the patient, make sure that their ID matches their ID band, and washing my hands and gathering my equipment. So gathering my equipment will include gloves, a pen light or flashlight, a small glass of water, and a stethoscope again. So then I'm going to explain my procedure to the patient and gain consent for what I'm going to be doing next. Okay, so firstly I'm going to be doing inspection. So I'm going to be expecting the color of hands and arms, and the color should be the same bilaterally. And then I can also check for hair distribution or lack thereof, and nails. So I'm making sure that the nails aren't cyanotic and that the hair is even throughout. And if there's less hair in one place, that could be a lack of oxygen. Okay, so then I'm going to palpate to assess the capillary refill time. So the normal capillary refill time is about 2 seconds. So if it's more than that, that could be an indication of dehydration or lack of oxygen. Okay, so next I'm going to be palpating the peripheral pulses. So the peripheral pulses go as is. So the first is the radial artery. So the radial pulses are bilaterally strong, so about a 2, and the artery walls have a resilient quality, so like a bounce. And then next is the ulnar artery. So the ulnar artery may or may not be detectable. So the brachial artery is next. So the brachial pulses are equal strength bilaterally. So the femoral pulse is next, and is strong and equal bilaterally. And then the popliteal pulse, so that's in back of the knee, that is not unusual for the popliteal pulse to be difficult to find or impossible to detect. So yet circulation to be normal. So next is the Dorsalis pedis, so pulses, so that's bilaterally strong as well, and the pulse should be congenitally absent from 5% to 10% and of the population. And then lastly, it's the posterior tibialis pulse, so that's by the tibial bone, and that is be strong bilaterally as well. And however, about 15% of healthy clients the pulse is absent. Okay, so after doing the pulses, I'm going to be inspecting the skin color on both legs. So the normal findings would be pink for lighter skin clients, or pink or red at times, viable, so like pink or red for darker skin clients as well. And then I'm going to be inspecting the hair distribution on the legs. So it should be equal bilaterally, and like I said before, and a lack thereof of hair could indicate lack of oxygen. And then I'm going to identify presence of edema. So there should be no edema or pitting or non-pitting present in the legs. And pitting is a depression of the legs when you touch. And then a lack of hair, like I said, is due to oxygen. So next is knowing how to stage edema. So it's checking the pulse, so like weak pulse, and I could also have to use a Doppler tool. So the grade of edemas are 1 is slight pitting, 2 is deeper than 1, and then 3 is a noticeably deep pit, or the extremity looks large. 4 is very deep pit, and the ground edema is extremely large as well. And then the pitting edema is associated with systematic problems such as heart failure or hypertension. Thank you.